All right, good afternoon. Welcome to the University of California, San Francisco's Philip R. Lee Institute for Health Policy Studies Grand Rounds, our monthly Grand Rounds for health policy. We are very happy to have everybody here today. Our speaker is Dr. Tomás Aragón, who is a physician, a doctorate of public health, and he is the director of the California Department of Public Health and our state public health officer. He's been in this role since January, so for 7 months now. Prior to taking on that role for the California Department of Public Health, Dr. Aragón was the health officer for the city and county of San Francisco and the director of the public health division for the city and county. He has served in public health leadership roles for more than 20 years, including roles such as communicable disease controller, deputy health officer, and such. And he also directed a public health emergency preparedness and response research and training center at UC Berkeley School of Public Health. As the California Department of Public Health director, he works through collaborative partnerships to mobilize communities and institutions to transform policies and systems towards a culture of equity, anti-racism, healing, and health for all people and our planet. He also has had a leading role in much of the more recent COVID-19 response, both at the city and county level before moving to the state government and now within the state government. And that is the topic of his presentation today. So I will hand it over to you, Dr. Aragón. Thank you so much for joining us today.
Thank you very much. I'm really happy to be here.
All right, I'm going to give one piece of housekeeping that I forgot. Please, everybody, enter any questions you might have. We will have time for Q&A at the end of a formal presentation. Please put your questions in the Q&A box. We do not have chat enabled. So just type in your questions into Q&A and we will have some time for those at the end of the presentation.
So good afternoon. If you can put up the first slide. Or should I do the slides from here?
Yep, we were testing those a moment ago. So Kat, do you got the slides or should Dr. Aragón put them up?
Are you able to by chance? Dr. Aragón?
Let me know if this works.
Yep, if you hit the slideshow button at the bottom, it should work.
How's that?
Perfect. Thank you.
Okay, let's give it a shot. Okay, so thank you very much. I'm really excited to be here speaking to a UCSF audience on policy. And when I was a health officer in San Francisco, I leaned heavily on UCSF. So and there's so many people that I can thank. I won't have. So I'll just name just a few because they had a big influence in the work that I did in the city and continue to inspire me here at the state level. So Diane Havlier, Naomi Bartok, Sohail Sood, Kirsten Bibbins Domingo, Margaret Hanley, George Rutherford, Priya Shetty, Bob Wachter, Monica Gandhi, Mike Reed, and from UC Berkeley, Maya Peterson, and Josh Schwab, and many, many more UCSF faculty that have been supportive of the work that we're doing here at the state and also when I was in San Francisco. I want to give special recognition to two other people, Dr. Mark Galley, who's a Secretary of Health and Human Services at the state, who's really the lead for everything that's happening across the state, and then Dr. Erica Pond, who's a state epidemiologist. So I'm going to go ahead and see if this works. Okay, I'm going to spend most of the time on number 3, but I will go quickly through number 1 and number 2, going over some of the data just to put context. I'll introduce a little bit about the topic of pundits. When Dr. Laura Smith asked me to come and speak, she says, well, talk a little bit about what it's like doing health policy making in an anti-science environment. So that's where I came up with a talk of pandemics, pundits, and policy. So I'll cover a little bit of that, sharing my perspective. So just to give a very quick update. So these are this is the epidemic curve for the United States. On the right-hand side is cases. And I'm sorry, on the left-hand side is cases, on the right-hand side is deaths. And one of the things you'll notice about the death curve is you'll see that large peak early on. So we were fortunate in California to really avoid primarily that large peak. And that's really from the policy decisions that were done here at the state and local level. And an important thing to realize is that at that time, we knew there's a lot we didn't know about SARS-CoV-2. The left-hand graph here is just a reminder of the racial disparities in infection and outcome that we've seen throughout the United States. And then on the right-hand side is a reminder of the variants. And currently, you'll see the orange bar there on the right-hand side, which is the Delta variant, which is increasing in proportion throughout the United States. And this slide is just a visual summary of, as of July 17th, looking at community transmission across the United States. And right now, so for California, the daily case rate is up to 8.1 per 100,000. So that would put us, with an average rate, would put us under substantial transmission. Our test positivity is 4.5%, and our effective reproductive number is 1.25. And this is from our dashboard that is online. On the left-hand side, you see cases, and on the right-hand side, you see the deaths. And as I mentioned, the current case rate is now up to 8.1. On the slide, it says 6.9, but that's as of a few days ago. So the case rates have been going up, as well as hospitalizations are beginning to go up as well. So across the United States, 97% of the hospitalized patients are unvaccinated persons, and we're seeing similar trends here in California. And in terms of vaccination, currently in California, we have 61.4% of those that are eligible fully vaccinated. And when you include the whole population, we have about half, 49%, that are still susceptible. And currently, the biggest group that we need to bring up the vaccination right now, between the ages of 12 and 17, 55% are unvaccinated. And then in terms of racial breakdown, among Asian Americans, 10% are unvaccinated. Among Black African Americans, almost 53% are unvaccinated. And among the Latinx population, about 50% are unvaccinated. So we still have significant proportions of the population that need the vaccine. This shows you cases, hospitalizations, and deaths. And the top curve for the left-hand side under cases is vaccination. Unvaccinated, I'm sorry. So for unvaccinated, it is currently 13 per 100,000 daily case rate. And on the bottom is 2 per 100,000. So if you take those two rates, you can approximate a vaccine effectiveness. So that calculates to a vaccine effectiveness of 85%. And these includes cases that are both mostly symptomatic, but also some asymptomatic patients. So there's a big disparity between that. So let me go ahead and just turn to some of the challenges we have making policy in the era of social media. And what I want to do is I want to sort of share with you my thinking about this, not to criticize, but really for us to reflect on how we're all vulnerable for some of what I'm about to talk about. So a pundit is a person who offers to mass media their opinion or commentary on a particular subject area on which they are knowledgeable to differing degrees. The cartoon on the right says, and in this corner, still undefined, Frank's long-held beliefs. And on the right hand, it says, are you coming to bed? I can't. This is important. What? Someone is wrong on the internet. And the idea being here is that mass media sort of draws our attention to point out all the inaccuracies that exist in the media. So I want to talk about some of the implications of that. And what I'm going to do is I'm going to summarize just a few key concepts from Adam Grant's recent book, Think Again. I absolutely recommend the book if you haven't read it. And you'll hopefully you'll begin to appreciate why I think his book is important and is timely for what's happening right now, especially on social media and what I'm about to just share with you. So he talks about the default mindset, some key cognitive biases. And so when I read this, I thought to myself, oh, I can see myself doing this. And in fact, we all do it because it's our default mindset. So he describes of us being of one of three modes, which is the preacher mode, where we defend and promote our deeply held beliefs; prosecutor mode, where we recognize flaws in other people's reasoning and marshal arguments to prove them wrong and win our case; or politician mode, where we seek to win over an audience, campaign, and lobby for approval of the audience. So if you reflect, you will find that you're oftentimes in one of these three modes. And when you're talking about social media and health policy related to COVID, and you're on a social media, especially you can catch a lot of this on Twitter. It gets very heated. And so when you combine this with a confirmation bias, desirability bias, and what he calls binary bias. So confirmation bias is seeing or seeking what we expect to see. Desirability bias, seeing or seeking what we want to see. And then binary bias. And I'm just going to read a sentence from his book. It's a basic human tendency to seek clarity and closure by simplifying a complex continuum into two categories. To paraphrase the humorist Robert Benchley, there are two kinds of people: those who divide the world into two kinds of people and those who don't. The other important concept that he points out in the book is the Dunning-Kruger effect, which many people have heard about, but he really emphasizes on what he calls the Dunning-Kruger trap. Which in the book he refers to it as Mount Stupid. So if you look on the graph, you'll see on the y-axis willingness to opine on a topic, and on the bottom, knowledge of that topic. So here's just a few quotes from the book. It's when we lack competence that we're most likely to be brimming with overconfidence. The less intelligent we are in a particular domain, the more we seem to overestimate our actual intelligence in that domain. The first rule of the Dunning-Kruger Club is that you do not know that you're a member of the Dunning-Kruger Club. And so this idea of overconfidence is something that's observed in beginners. So here's an article that's entitled "Overconfidence Among Beginners is a Little Learning a Dangerous Thing." And so this has actually been well studied in different fields, is that when you're a beginner, as you gain more experience in a specific topic, our confidence quickly outstrips our actual accuracy or our competence in a topic. So you'll see people becoming much more confident in expressing their novice opinion. And part of the reason why I'm bringing this up is that all of us are novices when it comes to the SARS-CoV-2 pandemic. All of us have been wrong. All of us have seen conventional wisdom go out the window, and all of us have been learning. And so this is really important for us to remember that. And I was trained in infectious diseases, and I was around when SARS-1 happened, and then also the H1N1 pandemic back in 2009. And I can tell you a lot of the assumptions that we made about how we think about the transmission of infectious diseases, we used our default thinking, and that's a lot of the policies were based on our default thinking, and many times there was a lot of uncertainty. So let me go to the next slide here. So this is just a cartoon. It says here, let me interrupt your experience with my confidence. So the reason why I'm going through this is because he's reminding us that if we're not careful, that if we just rely on the way we are, our default modes as human beings, we will find ourselves in this overconfidence cycle of pride, conviction, confirmation, desirability, and binary bias, and then validation of our biases. And we have sort of this vicious circle where people become more polarized, more certain. What he wants us to really focus on is what he calls the rethinking cycle, which he summarizes as really the scientific method. And it starts with humility, doubt, curiosity, and discovery. And so the scientific thinking is what is what he wants us to focus on. I'm going to just read a couple of sentences from his book. Recognizing our shortcomings opens the door to doubt. As we question our current understanding, we become curious about what information we're missing. That search leads us to new discoveries, which in turn maintain our humility by reinforcing how much we still have to learn. If knowledge is power, knowing what we don't know is wisdom. Scientific thinking favors humility over pride, doubt over certainty, and curiosity over closure. And so Dr. Schmidt asked me sort of, the idea of policymaking at the local and the state level. And I think for me, what's really helped me is sort of understanding both of these and sort of recognizing as we're deliberating and making decisions that we recognize that we can fall into the overconfidence cycle as individuals and as teams, and that's natural. And then how do we design processes so that we focus on scientific thinking? And so I'm going to spend the rest of the time focusing on that, the scientific thinking for policy decisions. I'm going to be focusing on decisions, and I'll show you in a second why that is. I'm going to focus on 3 examples. One is the Bay Area stay-at-home order on March 16, 2020. CDC masking guidance recommendations for fully vaccinated in May of 2021. And then the recent Los Angeles County universal masking requirement for public indoor settings. Masking is a good topic because there's just a lot of attention around it right now, and a lot of the emotion in the whole topic of masking. But it's a very practical to think through the issues. And as I was preparing this talk, I know that I'm speaking to some health policy folks, and so I pulled out my Eugene Bardock book, and I started. It's been a while since I looked at the book, and I started looking through it. I go, oh, this is fantastic, because actually this is the way the book is divided is pretty much the way that I think through problems. I approach problem solving primarily from the lens of decision making, and so that's what I'm going to give you. I'm going to share with you problem solving that's related to policy from the lens of decision making, and I hope to convince you that that's a really powerful way to do this. So on March 15th, Sunday morning, Dr. Grant Colfax sent me a text to say, let's get together with some of the Bay Area health officers to talk about some of the orders that we've been issuing in the Bay Area. We had been issuing many health orders, a lot of it having to do with decreasing capacity of gatherings. And Santa Clara limited gatherings to 1,000, and then another county to 50, and eventually got down to San Mateo limited gatherings to 50 people. And this happened over a series of days. And so things were changing very, very rapidly. So we got on the call, we got on the phone with Dr. Sarah Cody, Scott Morrow, myself and Grant. And, what we were doing is we were thinking about, we're seeing what's happening, especially what's happening in Italy, and sort of anticipating, okay, what do we have in our toolbox that we haven't used? And really, there were really two big things that we had not used. One was shelter in place, which had not been done in any time recent in the United States, but we saw it done in other countries. And then universal masking. And so we ended the call by coming up with a consensus. You know what? Let's do. I think shelter in place might be good as a recommendation. Sarah Cody called really just a few hours later, after a lot of reflection, and she says it's got to be in order. We have to do this as an order. And so then we brought everybody together from the 6 Bay Area counties that represents 7 health jurisdictions, and we started deliberating on whether we should do a shelter in place order. And after a lot of deliberation, we decided that was the right thing to do. We had attorneys with us to help us understand some of the issues from a legal perspective. And I do want to give a big shout out to Dr. Sarah Cody, who was really the person who had the premonition of what was happening, and really was the one that really sort of brought us together and advocated and helped us really think through why this made sense. And so within 24 hours, by the next day, we've basically working around the clock with many attorneys, the health officers, elected officials. And I do want to comment that the elected officials were very supportive. And I think that's what made it possible in San Francisco, or the Bay Area, I should say, is that we had a tremendous amount of support from the elected officials. And so made a big difference. We wrote an article. There's a link at the bottom of the slide that goes through in a lot of detail of that decision-making process. The article is really written as a reconstruction or unpacking everything that went into making that decision. It's not something that happened really, although the deliberation really happened in a really short period of time, in a matter of few hours. The whole process was a process that really took weeks, because we had been making decisions around other topics. And so I'm going to give you a summary of the article. So here are the key points that I want you to think about. So one was understanding the scope of legal authority and develop strong relationships with legal counsel. And this has been a really important issue around COVID. People make the assumption that because health officers have broad authority, that they can do anything they want. And that's not the case. While the authority is broad, we can't do things that are unconstitutional, and there are checks and balances on what we do. So if we were able to convince the attorneys to do an order that did not make sense, we would not be. It would not go very far, because we have a court system. We have a system that can put a check on things that don't make sense, and so that's really important. The next one here says strengthen your meta leadership network of trusted relationships. And I would say probably that's in something like the pandemic is these relationships are really critical. Use causal thinking and simple causal graphs to organize your problem solving. I'm going to cover that. Decision problems are embedded in the problem solving process. Sometimes decisions are intuitive and fast, and sometimes they require deliberation and decision quality. Causal assumptions and predictions are implicit in every decision. Make them explicit. Predictions improve learning. And that's a really important point, is that at the end of the day, every decision has a causal assumption and has a prediction. So your causal reasoning and your probabilistic reasoning are really important for decision making and how it connects to evidence. Human intuition cannot calculate probabilities, especially for novel events. Therefore, embrace intellectual humility and choose curiosity over certainty. Surround yourself with persons who think differently than you and who can vigorously challenge your thinking and assumptions. Ensure psychological safety. And then crisis decisions have multiple dimensions and stakeholders that require our attention. So the article does cover other tools. I'm only gonna cover just a couple of them that I use. And what I'm doing is I'm sharing with you how I think through some of these problems. So this is just a summary of the meta leadership framework that's been developed and has been around for more than 10 years. And so the idea here is that the person, in this case, a health officer, the situation is COVID, and the connectivity to both people above us, below us, within our organizations and outside our organizations. And the Association of Bay Area Health Officials is a great example of a meta leadership network. So for example, they just recently recommended universal indoor masking in the Bay Area because of the Delta variant that's spreading. So this is a really important component, and part of the reason why we were able to make a decision that day on March 15th is because we had a long relationship of really problem solving. There was a tremendous amount of psychological safety. We could vigorously disagree with each other, and we would talk through issues, and we continue to have a tremendous amount of respect, even though sometimes our opinions were totally opposite. And I think that's what really, that was very useful. And I would say that that's something that I've noticed here at the State Health Department that I would find, that's one of the things I've noticed at the State Health Department is that there's a lot of psychological safety when we're deliberating the decisions. And that's been incredibly helpful. And one of the truisms about decision making is that there's never an absolute right answer. There are only trade-offs, and I'm going to go over that in a second. So the way that I conceptualize this process, I just call it decision intelligence. And this decision intelligence has 4 different components. One is problem solving, decision quality, which I'm going to cover in a second. The third one is just getting better. You want to learn from what your decision-making processes and problem solving, you want to get better. And then there's just all the sciences that you need to support it. And the sciences that really become important are going to be behavioral economics, data science, and implementation science. So it says here, decision-making is our most important daily activity. A decision is a choice between 2 or more policy alternatives that involves an irrevocable allocation of resources. Decisions drive policy. Every decision has causal assumptions, predictions, trade-offs, and opportunity costs. Decisions involve human psychology, intuition, emotions, and group dynamics. I'm only going to cover the causal thinking component. So one of the diagrams that I carry in my mind, and I have to tell you that a lot of the way that I've integrated is really been influenced by quality improvement and PDSA. Most people who do quality improvement are familiar with Plan, Do, Study, Act, which is basically the scientific thinking. And so the diagram that I carry in my mind is a diagram right there at the left. Defining a problem, thinking about the consequences, thinking about the root causes, and then designing countermeasures. And you see their prevention, control, and mitigation. And what I do is that when I'm thinking about a problem, I really try to put it in this framework. And I think if you do that, it really helps tremendously to be able to articulate the different things. I'm going to show you something from. So this is what I put together in August 2020 of the summer. So we were just through our summer surge. And so I took that diagram, and basically this was my framework for problem solving for really the whole pandemic. On the left-hand side, you see drivers. So you'll see mobility, network, and then you see setting, indoors versus outdoors, ventilation, fomites. Then the next one you see is contacts, activities like eating or drinking, face coverings, and hand washing. Right below that, you see different interventions, like SIP means shelter in place, social gathering number, IPC stands for infection prevention and control, et cetera, et cetera. You'll see there face coverings. Then you see what we're trying to do is we're trying to prevent transmission events in different settings, primarily in social gatherings and in workplaces. And of course, the place where it's really hard to prevent transmission events is in households. That leads to asymptomatic infections or symptomatic infections, hospitalizations, deaths, recovery, testing, cases. And so now you can begin to see the outcome measures that we look at: deaths, hospitalizations, daily case rates, test positivity. All of these things drive transmission events. So there's a feedback loop, and then we have all our interventions. And then what I did is that I put a letter on each one of these. B for behavioral and E for environmental and engineering. And then the insights from just this diagram and just the experience of being in communicable disease control. Most drivers are behavioral. Outcome measures are insufficient to infer drivers. And this is actually really, really critical. And this is one of the big gap areas that we had in policymaking, was not sufficient research to really identify what the primary drivers were. It took a while to get the case control studies up to begin to identify that, and then metrics which facilitate monitoring, early warning. PCMS stands for prevention, containment, mitigation, and suppression interventions. All those things that you see up there, that you see there on the left-hand bottom side, and then investigation and evaluation. So just to let you know, so this is very high level. The amount of time and resources to implement all this involved just in San Francisco. When San Francisco was activated, we had close to 500 people down at the Moscone Center and the Emergency Operations Center. And then when you included all the people in the field, we had, really over 1,000 people who were activated. A huge amount of work. I was focusing primarily at the policy level with clinical and public health policy making, and then health orders. And so we spent a lot of time with scientists, getting advice. Actually, a lot of them were UCSF scientists, giving us their wisdom and helping us think through some of these issues. And then working with the attorneys to sort of craft orders that were gonna be legally defensible, but also make sense from a public health perspective. And in general, one of the principles of public health interventions is that you want to do the least restrictive intervention that's going to get the job done. We're not trying to do necessarily the most effective. We want to minimize any disruption of individual rights. And so that's part of the trade-off. And so although this is high level, I could just tell you that the amount of work that goes into this is just enormous. And it's just a whole team of people. And it's true here also at the state level. So if you take San Francisco, you multiply that many times, and that's what's happening at the state level, where it's even more complicated because every county, every region of the state is very different. So for decision quality, this is a simple framework that was developed many years ago by decision scientists. And it's just, the 6 criteria that goes into decision making. And it really, you could use this really as a checklist to make sure a good decision. Spend some time thinking about these different criteria. The frame is sort of the context, the problem definition, who you're gonna involve. Information is information, and this is where the big, the data systems comes in. So to the extent that you have really timely, accurate data, that gives you the situational awareness. And oftentimes we don't have data. Alternatives, the reasoning process, commitment by the people that are going to implement it. Remember I said every decision has a causal assumption. Well, those are actions that we believe are going to have consequences that are going to contribute to results that are going to hopefully achieve our goals, and that may have other impacts beyond that. And of course, there are always trade-offs, and there are always opportunity costs. So the best decision not chosen or not considered. So opportunity costs are really important. And so this is something you can carry with you. It's easy to remember this because it's very intuitive. And sort of the takeaway that I have for folks is that this process of choosing is involved really in the whole problem solving process. So when you're defining the problem, are we working on the right problem? The consequence analysis, thinking about the consequences, the causal analysis, both the root causes, but then evaluating your interventions, and then selecting countermeasures. So all of this is happening. Oftentimes this happens through intuition. And sometimes for me, it's important to when you can to slow down, take a pause, and to think about, are we doing this correctly? So this is sort of a reminder. And you can see, so for example, when we did our shelter in place order, we had a very distinct causal model that would be very different than if I were, for example, a hospital CEO. A hospital CEO might be looking at some of the same outcomes, like hospitalizations and people who are dying, but might be focusing on just hospital surge. We were focusing on interrupting transmission in the community. So that causal framework that we have really leads to a whole different set of solutions and challenges. So the other thing I want to just cover really quickly, which I see this as a challenge that people have when they're doing problem solving, is to make sure that you think through your simple causal models. So you can see there cause effect, or you can think of this as hypothesis and evidence. And human beings are naturally good at causal reasoning. So what is the probability of an effect given a cause? And so our brains are wired to look for causal reasoning because that's how we learn. What we're not good at, it turns out, is that we're not good at evidential reasoning, which is really the inverse probability. And in diagnostic, you'll hear people talk about predictive reasoning or diagnostic reasoning. This is used in clinical medicine for diagnostic tests, but it applies to pretty much everything that we do. Remember, every decision has a causal assumption and it has a prediction. And so at a minimum, you're going to have two nodes that are operating, and oftentimes it's a hypothesis, and we're looking at evidence. So oftentimes what we're trying to do evidential reasoning, but people don't realize the difference between causal reasoning and evidential reasoning, and that it involves the inverse probabilities. And so people make mistakes in their thinking, and the mistakes in their thinking actually oftentimes leads to false conclusions. And you combine that with confirmation bias and desirability bias, you can see how people develop really strong belief systems that are not founded on good reasoning. And this is also true at the policymaking stage. And the reason why I bring this up is that if we go back to when we're talking about pundits, oftentimes people who are giving information aren't always very clear on how they came to their conclusions. So I'm going to go. So this is basically the way that causal reasoning is connected to evidential reasoning is through Bayes' theorem, and Bayes' theorem, from a conceptual perspective, is how we learn. And so I'm going to just give you an example that's happening right now in across the United States. I'm going to focus on the text on the right-hand side. So some are confusing the proportion of hospitalized patients that are vaccinated. So that's the probability of being vaccinated given hospitalizations, with the proportion of vaccinated persons that are hospitalized. Well, the probability of being hospitalized given vaccine, that is the vaccine effectiveness for severe disease outcomes. So when you put this into Bayes formula, you can see that on the right-hand side, people are looking at the probability of being vaccinated given hospitalizations as evidence that the vaccine is failing. And so you see this happening where people are saying, but look at all these breakthrough infections, the vaccine must be failing. But when you look at the right-hand side of the equation, that it's really a function of the probability of being vaccinated, which is vaccine coverage, and then the probability of hospitalization given vaccines, which is, it's called the likelihood ratio, but for our example, that really is vaccine effectiveness. And so being aware of causal reasoning, evidential reasoning, how they connect through Bayes' theorem, and how the fallacy of inverse probabilities is going to make our thinking hard if we're not careful. I see this all the time. And it's incredibly important, because otherwise you're going to be drawing some bad inferences and you're going to be making some bad policies. And there are many examples of bad policies being done across the United States. I'm going to go to the next example, which is indoor masking. So on the left-hand side, you see vaccines. Before vaccines, P1 is just the policy of universal indoor masking. So that affects M, masking indoors, and that affects I, which is infection indoors. So that's what existed before vaccines. With vaccines, basically the same causal graph, except now that we have vaccines. With vaccines, we know that vaccines are both effective, very effective in preventing infection, especially severe outcomes, and that there is some decreased probability of transmitting to others. So you're less infectious. How much less infectious? It still has not been completely quantified, but there are estimates anywhere between 30 to 50% less infectious. And there's a lot less folks that are infected and vaccinated, so they don't contribute a lot at the population level, yet it's important. That's the assumptions that the CDC was acting. So the CDC policy, they made the decision to recommend, and part of the rationale is that if we allow vaccinated people to be unmasked indoors, then that benefit would encourage unvaccinated people to become vaccinated. So that's now P2, that's a CDC policy that's impacting masking policy for people who are vaccinated, with the assumption that it would activate M to V and encourage people to get vaccinated so that we'd have more people indoors. There's a problem. There's actually two problems. I'm going to only mention one of them, and I'll allude to the other one, and that is belief systems. So we know that there are certain people who have a belief system where they're unlikely to choose to get vaccinated, and they're also unlikely to wear a mask. And that's a problem if you don't have a vaccine verification system and enforcement. So what's happened now is that you have more people, in some ways, the person who's unvaccinated now can, because it's through self-attestation, you see signs when you're entering a public indoor space that if you're unvaccinated, you're required to wear a mask. But of course, no one verifies that you're vaccinated or unvaccinated. And so pretty much you don't know. And there are surveys that are coming out that suggest that persons who are unvaccinated are also not wearing masks indoors when they ask people about their behaviors. And so there's more research coming out on that. So this is what I believe is the causal pathway that's acting. And we could actually put one more causal node, which is going to be vaccine verification, with an arrow to M and an arrow to V, which is vaccines. So what Los Angeles County did is that they implemented a universal masking indoors to decouple masking with vaccinations. So whether you're vaccinated or not, everybody has to wear a mask indoors. It's required now in LA County. And so they've decoupled that. And the idea here is to get everybody to mask up, whether you're vaccinated or not. And that the biggest benefit is going to come from those who are unvaccinated because they're at risk for infection, transmission, and they're also more likely to not wear a mask indoors. So that's really the causal model that's behind the LA County policy. So I'm just going to just end with this slide. So I went through a little bit of the data of giving you an update what's happening with COVID in the US and California. I started off with the idea of pundits and how all of us really are pundits in a sense because we're out speaking to folks. And for all of us to really reflect and to be careful because of our default mode, to really be very intentional, to put yourself into what he calls the rethinking cycle or scientific thinking. And then I really just built off scientific thinking and really problem solving and decision making to sort of really have an integrated framework to think about how these concepts are really critical, absolutely critical. And every time when I have time to sit down and to get my few causal graphs created, it all of a sudden what it does is that it provides not just clarity to me, but when I hear other people talking about what they think is happening or what they think is going to work, it helps me also understand what their causal thinking is because I had to force myself to think about what are the key variables, how might they be related. So just the process of preparing these grand rounds helped me sort of nail down how things like belief systems, vaccine verification, masking policy, and vaccination coverage are all related to each other, connected to policies. So I'm going to go ahead and let me see. I think that's the last. That was the end. There, I do have a blog. If you want to learn a little bit about some of what I talked about, you can go there. Read the article that I mentioned. There are some other really practical tools in that article that I wish I had time to go over. And then I have my contact information. So I'm going to go ahead and just stop for questions.
Great, thank you so much. We have a few questions that have come in. One asked if there is any place where these slides might be posted. We usually don't post them on our website, but if you are willing to have them shared, we might be able to come up with a way to do that.
Yeah, that's fine. You can absolutely share the slides.
Great. We'll see if we can get a spot on our website for people to look for them. So the first question that came in is, what lessons have we learned to implement related to inequity factors, especially the social factors around COVID-19?
Yeah, that's a really great question, and I think, and it has been a, I can tell you that when I was in San Francisco and even here at the state, equity as a core principle in every single thing that we do is really critical. And one thing we've learned from COVID-19 is that if we allow transmission to happen in the community, the people who are going to be the most impacted are going to be low-income communities and communities of color, especially the essential workers and their households. And that's one of the reasons, why people feel very strongly about really trying to mitigate transmission. And I know, for example, in Los Angeles County, Barbara Ferrer, who's the health director there, she has a really strong equity lens, and it is an important factor that they use in making their decisions, because they recognize that, especially right now, we still have a large proportion of the Latinx population that's not vaccinated, and even a larger proportion of the African-American population that's not vaccinated. And they're at higher risk for complications because of chronic diseases and those existing racial inequities that exist. So that's incredibly important.
So, the next couple of questions are related to these issues around exposures and risks for COVID. At this point, there are, of course, different populations that are not yet vaccinated. What do we know about those populations and why they have not yet gotten the vaccine? And are we seeing any small changes now as the Delta variant is moving around, or are there people who are rethinking those decisions?
Yeah, there are a lot of surveys are being done across the United States, really trying to understand. And it's really it's a spectrum. It's a spectrum of people. There are people that have misinformation. There are people who have disinformation, depending on who you listen to. So disinformation being information that's intentionally put out to discourage vaccinations. There are people who basically who are waiting. They're waiting for a variety of reasons. But one is, are we going to learn more about the safety of the vaccines? And then there are people who are, just ideologically opposed to them, either for a political or religious reason. And so there's a tremendous amount of work happening at the state level to try to reach the diversity of communities that are being impacted. And a lot of it's gotten to the point where a lot of it is a ground game, having people in the community and sometimes going door to door. An example sort of a really good example has actually been in San Francisco, and they did publish in the New England Journal of Medicine Catalyst. Diane Havlier and her team with the Latino Task Force really sort of summarized their approach in San Francisco, which was a lot of it was really building trust. It took, if you saw, San Francisco was a great example that a big reason why the vaccine efforts were successful was because there was a lot of relationship building that happened months and months and months before vaccines were even available. A lot of it had to do with testing, wraparound services, really plugging into community ingenuity and wisdom. And really letting them really lead the efforts, and then us, public health, really supporting the efforts. So that type of work is being done across the state. It moves at a different pace. It's a lot slower. And this is a challenge with the Delta variant, is that the Delta variant is spreading so fast that people who are unvaccinated are getting infected.
Yeah, I think a number of our faculty at UCSF were involved in some of that early stage work that helped lay the groundwork for the ground game of the vaccine. And we're really proud of and glad to see our community out there with testing programs and such, because we knew that was going to make a difference. Somebody asked about some of the different policy incentives that have been put into play for vaccination, the lotteries, mandates for workplaces and school, some of the mandates around travel requirements, and how well do you sense that those are reaching the unvaccinated, and do they seem to work better with some populations versus others?
Oh, that's a good question. I don't have the answer to that. I know that it is being studied, and I know some research was done with Ohio, where at least the inference is that some of the Ohio lotteries did not have a big impact. I think we're going to have to wait for the research to be done. So when you think about vaccines, there's really three ways of thinking about vaccines. You can recommend them, you can mandate them, or you can provide incentives. And so we're not in a position that we're going to be mandating vaccines. The mandate of vaccines can happen at the employer or at the institutional level, but we don't foresee that government would be doing that. It would really, we foresee that any type of vaccine mandate in the future would really come through a legislative process to make sure that really there's input. So those are the three things: recommendations, mandates, and incentives. We were doing recommendations, and then the incentives was another strategy to try to get as many people vaccinated.
All right, I'm going to try to squeeze in two more questions, although I know we're getting towards the top of the hour. One question that's really intriguing to me is there more that the technology industry or corporate interests can be doing to help manage this pandemic and prepare for the next one?
There's always more, and I think you're seeing that around the vaccine verification system. There are technology solutions. Like right now, we have a digital vaccine record from that's open source. So if you were vaccinated in California, you're going to be in our immunization registry. You can go and actually get a digital vaccine record for your vaccination. And then now there's an open source reader. It's called a smart health card. And both Apple has the ability to do that with its updated operating system for the iPhones. The Android systems can do that. And so you're going to be seeing, the technology solutions are going to help make it easier to verify people's vaccine status around non-essential events. So things like entertainment. Actually, in the Chronicle, they were talking. There was an association of bar owners that are talking about requiring vaccine verifications for people who are going into bars in San Francisco. So vaccine verification is a really good is a good pathway to try to minimize transmission. We want to get the effective reproductive number less than 1, keep it as low as possible, and get community immunity up through vaccination.
So one last question, if I can indulge. So one of our faculty asked about accounting for uncertainties in the steps you outlined. That the processes of policy decision-making are logical and really important, but given all of the uncertainties around COVID transmission science and treatment science, how have you been able to account for that going through this process?
Yeah, it's a fantastic question. I think it's very hard. It's very hard, and for policymakers that are conducting research, you know how hard it is and how long it takes to conduct good research. One of the things that I noticed, because I've been in public health for so long, I've had the opportunity to really see the evolution. So for this pandemic, I was really pleased by the amount of modeling capabilities. So we had modelers from UC Berkeley, Stanford, other universities who were doing modeling and incorporating a lot of the uncertainty into the models. And so our predictive analytics did take that into account. And we need to be able to do more of that. And that's sort of part of one of my longer term goals is into the future is to over time to really build up that capability, because absolutely uncertainty is one of the big challenges that we have. And and there are ways to think about uncertainty, but it's not easy. It's not. And when we made our decision on May 15th. We were taking into account uncertainty, but we were doing it primarily from an intuitive perspective, using the data that was emerging out of Italy, looking at the exponential rise of cases, and sort of talking through what are the implications of not acting versus acting. And we decided that if we acted late, we would get all the downsides of shutting down the economy and little of the benefit of protecting health. And by acting early, we would optimize protecting health. And so, that's the way we did it at that time. But absolutely, we need more tools. And this is where the public health and academic partnerships are really critical. And we hope the state health department really hopes to build that out in the coming years so that we're prepared for the next pandemic and other public health issues that we have to deal with.
Great. Thank you so much for staying over a couple of extra minutes. And thank you to our audience for joining us for today with Dr. Tomás Aragón for our monthly health policy grand rounds. And we will be back next month with Dr. Marianne Bittler from UC Davis as our speaker. So thank you so much. Have a good rest of your day.
Thank you, everyone. Be safe.